Type 2 inflammation inhibiting systemic treatments for atopic dermatitis offer more targeted therapy for patients whose disease is not adequately controlled by topical treatment. In this two-part special episode of Beyond the Headlines, Doctors George Martin and Eric Simpson and nurse practitioner Lakshmi Aldrich provide an overview of atopic dermatitis pathogenesis and share recommendations for appropriate utilization of systemic therapies. Part 1 focuses on the pathogenesis of AD, the comorbidities associated with this condition, AD's impact on patients' quality of life, and when to consider systemic therapy for AD.
Greetings. I'm Dr. George Martin, a medical dermatologist from Maui, and today I'd like to host this podcast, and joining me will be Dr. Eric Simpson and nurse practitioner extraordinaire Lakshmi Aldrich. Both hail from Oregon, and I'd like them to tell me a little bit about themselves. Lakshmi?
Hi, George. I'm delighted to be a part of this podcast. I'm from Portland, Oregon, and I've been practicing medical dermatology for the past 24 years, and I'm delighted to be talking about atopic dermatitis, a subject that's near and dear to my heart since I've been not only a provider, but a patient for many years. So looking forward to our discussion.
And Eric?
Yeah, hi. I'm upset, Lakshmi. I think you got me by 2 years. I always say 20 years now that I've been practicing dermatology, and practice is just that. Some people call me an atopic dermatologist, but I do more than just atopic dermatitis, skin cancer and whatnot. So no, it's a joy to be here with you, George, to talk about my favorite topic.
I've been practicing medical dermatology for approximately 40 years, having been a resident as early as 1985, and over that time treated thousands of patients with atopic dermatitis, and watched really our understanding of the pathogenesis and the disease burden change over time. We realize how severely it affects individuals, but most importantly, we watched the current therapeutic landscape evolve. And so really the subject of today's discussion among the three of us is, how do we appropriately utilize the systemic therapies that we currently have available to us in terms of systemic therapies? And that includes dupilumab and tralokinumab and now lebrikizumab. And of course, the JAK inhibitors, abrocitinib and upadacitinib that are approved in the United States. And let us not forget that baricitinib is approved in different countries for children as young as 2 years of age. So, we're going to talk a little bit about how these all fit into our practices and how we can give guidance to our listeners. So let's talk a little bit about the overview of the pathogenesis of atopic dermatitis. And let's just take this brief highlight reel, what atopic dermatitis actually is, for those of you who are new to dermatology, and then we'll delve more deeply. So as many of our listeners know, atopic dermatitis is really, it's common. It's a chronic inflammatory disease of the skin. It's characterized by a relapsing pattern of itching. We know that it's a Th2-driven disease, mainly an allergic diathesis-driven disease. And as we look at atopic dermatitis, we recognize it's primarily a pediatric problem, with about 60% of patients presenting before 1 year of age. And by age 5, about 90% of patients with AD will be affected by age 5. If you stop and think about the magnitude of this problem, is that when you look at children in the United States, somewhere between 50 and 30% of children have some degree of atopic dermatitis. Fortunately, the vast majority have really mild disease, but this is a significant burden. What's also come to light is that while atopic dermatitis affects, we're guessing somewhere around 13% of children, 7% of adults are affected by AD. And it turns out that about 1 in 4 adults with AD have adult onset atopic dermatitis. And about somewhere between a third and a half of these have moderate disease. So for years, we had this sort of nondescript term eczema for these patients. And the reality is that these individuals have atopic dermatitis. Well, atopic dermatitis is a clinical diagnosis. And that's why, particularly in really young children and particularly older individuals, it's been hard to nail the diagnosis of atopic dermatitis down, because there's no biomarkers to distinguish atopic dermatitis from other skin conditions that can mimic atopic dermatitis. And so in part, we rely a lot on the family history to establish a diagnosis. And we recognize that also that there's not just the genetics of sort of the skin barrier, but also the immunologic profile of these individuals. And also there's genetic sort of barrier dysfunction in these patients. And there's sort of this non-genetic immunology more in the way of allergy affecting these patients. And so atopic dermatitis, we've come to understand, is a very complex disease involving numerous cytokines, but central to it all is this sort of Th2 pathway allergic diathesis.
One quick point on
Yes.
diagnosis, and I think as we move, a lot of the criteria and whatnot for diagnosis and also pathophysiology, understanding like the disease and skin of color. When I was looking at recently at the criteria for diagnosis, it's like they don't mention extensor only in kids. And we have a lot of adult patients who have extensor disease only, especially in skin of color or these nummular patterns. And then just one other point is that I think both of you all see is trying to diagnose atopic dermatitis with elderly onset. I think we're just at the beginnings of trying to understand how to diagnose that and and what the pathophysiology is. Because I'm sure both of you, we get these biopsies back as eczema of unknown origin or drug eruption. And these are like extremely itchy people that respond to type 2 blockade in general. But I think I don't have a name for it. But I know all of you see this condition.
So Lakshya and Eric, talk to me about how atopic dermatitis affects the quality of life in your patients with AD.
So I'll go ahead and start. I definitely, again, having been a patient myself, we know that if you think about the majority of these patients being young children where the disease is manifesting itself and the quality of life impact is huge. The primary thing that we think about with AD is the impact of itch on their quality of life. Pruritic conditions, atopic dermatitis being probably the most significant, or the one that we think about as the itchiest of disorders. When you think about little children who suffer with this, it's not just the children in the family, the child, it's the entire family that is impacted. No one in the house is sleeping. The quality of their ability to focus at school or at work for those parents is significantly impaired. So when sleep is impaired, we're also understanding all the other comorbidities now associated with AD. Children who have moderate to severe atopic dermatitis have a higher risk of developing ADHD, having problems with growth, having sleep disorders, and also having social anxiety and not being able to develop those skills that help them fit into society. These are all things that start very early on in life. And then if the disease remains under controlled or not controlled enough, where the quality of life, including sleep, and their ability to focus is impaired, their quality of life is going to be impaired into adolescence and even into adulthood. And as adults who get adult onset, this can have a huge impact on quality of life, again, for all of the same reasons. If they're itching all of the time, they are not sleeping, or as adults, if they're getting heavily sedated to help control their itch, inappropriately so, without addressing the mechanism of action of the disease, then their sedation is also going to impact their ability to function in life, engage in relationships. And again, all of that is framed within their ability to have a really high quality of life.
I mean, I have nothing to add. Is an excellent explanation of the impact on itch from Lakshya on the whole family, on the patient. I would just say it's the only thing to add is that it's kind of one of the privileges of being a physician is hearing these stories from patients and how it impacts their life, and every patient is different. And it's sometimes it comes down to the little things like patients not able to they don't want to hold hands with their spouse or their boyfriend, girlfriend, or they don't want to lend their racket over to a friend because there's blood all over the thing. All these like little things that can impact someone's self-esteem, social life. And then if you meet a patient who says, it doesn't really impact me, and you see that they have pretty severe disease, once you start delving in, then you realize that they've changed their entire life based on their disease. And so, yeah, it doesn't impact them because their life is now just within the house only. So it could be a very isolating disease, emotionally traumatic. Lots of patients walk around with guilt, thinking they've caused it themselves because physicians or others have told them, if you just stop scratching, this should go away. So it's that's what's made me really passionate about researching this condition, because of that traumatic burden that patients walk around with every day.
And let me digress a little bit on the topic of itch, because it's central to the disease state. And being an atopic dermatitis patient myself, I realize it can absolutely drive you crazy. But when I was a first year derm resident in 1985, and atopic dermatitis patients came into the clinic, I was amazed by the fact that these patients just didn't respond to antihistamines. And the only way they did respond was if you snowed them with diphenhydramine, Benadryl. And I'm like, well, how is it an itchy disease and it doesn't respond to antihistamines? So fast forward, all of the research on itch has come to the fact that we now have an understanding there's really two different types of pathways for itch. One is the histaminic pathway and histamine neurons that are sensitized by histamine. But that's not atopic dermatitis. That's more of another allergic associated thing. It turns out that, and you both can comment on this, that atopic dermatitis is driven by non-histamine sensory nerves that have receptors for things like IL-13, IL-4, TSLP, IL-31, on and on and on. And those cytokines that are elevated in the skin of atopic dermatitis patients are actually driving the itch. And it's not until the development of what we're about to chat, until the development of both biologics and JAK inhibitors that impact these cytokines, do we see significant, substantial, and rapid improvement in itch. And I would ask both of you just to briefly comment on how itch is impacted by systemic therapies.
Yeah, I think that's a great point. When we think about atopic dermatitis, and to your point that so many patients have a huge amount of guilt because they've been told that they need to moisturize and the itch will get better, and if they need to take their antihistamines and the itch will get better. And to your point that this is a completely different animal when it comes to the itch associated with atopic dermatitis. Hence the new guidelines that have come out from the task force as well as AAD that really look at the importance of systemically treating our patients who are not well controlled with topicals. And I think that all three of us who have been doing this work for many years can look at a patient sitting in front of us and very quickly identify whether the patient is a candidate for systemic treatment. And we tend to be more quickly moving towards systemic treatment. But I think that is where a key learning point is that the topicals, and what our initial understanding was, this was really a skin barrier disruptive condition. The action was at the skin level. It was important to heal the epidermis and put the lipids back into the skin, and then this would be controlled. We now know that that is not the case. 25 years later, we're where psoriasis was. We would never think about putting topicals on a psoriasis patient and calling it good. We know that the immunological factors that are mediating the disease are not going to be impacted enough with topicals to truly quell the fire. We need to be thinking about that in the same way with atopic dermatitis. Topicals certainly have an important role and can be very effective, used appropriately in cases of mild localized disease. But when you have a patient who may even have mild or very low body surface area involvement, but they note that their itch is all over, that is a patient who requires systemic treatment to specifically target those itch cytokines, IL-31, IL-13, even IL-4.
Yeah, I totally agree. If your parents are using mittens for scratching or asking for antihistamine refills for itch, my response is usually you just need to treat the eczema more aggressively. So that's a good, if you're thinking of writing hydroxyzine, I think of course it's appropriate for allergic comorbidities, but if it's for the itch of eczema, as George pointed out, it's not going to work. And it's a sign to you as a clinician, you're not being aggressive, or at least not offering aggressive enough treatments. Now, some patients don't want those. And so I'll have some patients who say, well, Doc, okay, yeah, my skin's better with these topicals, phototherapy, but do you have anything for the itch? And I said, we need to treat your eczema more aggressively. I don't have something separate for the itch. The eczema is the itch. That's what's causing the itch. And so anti-inflammatory approaches to control eczema will naturally control the itch. And the studies bear that out very nicely.
So when you have a patient sitting in front of you and their family members are surrounding them, and you have the discussion about it's time to switch you to a systemic therapy, what is your specific threshold in one sentence for when you choose to put that patient on systemic therapy, where enough is enough? Lakshi, what do you tell the patient and their family at that point, if it's a child?
I really lead with excitement and just say, I think we've reached the point where we need to move to the next step of really getting control of your disease and improving your quality of life. And I'm really excited that we have these new opportunities to treat you effectively, quickly, and safely. And that's the one-liner that I open with, and it kind of just gives them hope. And I found that that's leads the way to opening the door to discuss the options that we have.
Eric, what's your approach to these patients?
It's different depending on the situation, but I mean, one question I've been asking just at the beginning, or if, I'll go through the spiel of, I do ask what's their impression of the condition, like what are, and you can kind of get an idea of what they've been through, where they've been, their journey, what's the impression of why you have this, or how you got this. And after that, though, to find out where we are on treatment, I let people know that I do kind of split people into two different groups, and I ask the patient, they're actually pretty good at it, if not 100% correct. I said, if I have really good topical, creams and ointments to control your condition, are you in that group of patients, or are you in a group of patients where you don't think creams and ointments are going to be satisfactory for the next 10 to 20 years? I mean, it's about 100% accuracy when the patient tells you, I don't think creams and oils are going to be the answer for me. And so they know. You just ask them. Is it because what we don't realize on our side is that we think we've done a great job by, I'm going to give you hydrocortisone for your face, I'm going to try some here, but then I'm going to give you some beta-methylation clobetasol on the wrist part, maybe some non-steroidal, and then I got a lotion for this. And we think we've done an awesome job because we've really considered everything and we've written all these prescriptions. It's impossible to use in a chronic disease. That's just not feasible. And we don't think about that feasibility. And so that's why a patient's experience is kind of the best. And then it's very obvious that we're ready to talk about systemic therapy.
The American Academy of Dermatology and the American Academy of Allergy, Asthma, and Immunology and American College of Allergy, Asthma, and Immunology Joint Task Force recently released guidelines that cover the introduction of systemic therapy in AD. Doctors Martin and Simpson and Ms. Aldrich weigh in on the recommendations.
So recently we've had the AD come out with their guidelines on the use of systemic therapies. And of course, we have the Allergy Society coming out with their task force on, when to introduce systemic therapies. And, a lot of times we get pushback from insurance companies that you have to jump through all these hoops. If you combine both guidelines, what is their position on when it's appropriate to switch to a systemic therapy? Because obviously when you have a guidelines backing your decision, you can put it right in front of an insurance company to then issue a systemic therapy. So where does that sit in both guidelines? What is their threshold to recommend?
I believe the AAD guidelines, kind of parrot the International Eczema Council guidelines of, failure of a aggressive topical approach to the disease. And when we went through that exercise back in 2017, there was, and it was international, and there was no threshold. I mean, everyone was pretty much unanimous that there was no thresholds, there was no BSA. It was really, can you get improvement in quality of life that's adequate with an appropriate topical therapy approach? And I think that what's missed a lot, and maybe this is kind of missed in the allergy guidelines, the Quad AI guidelines, the Joint Task Force, is, there, and I'm glad you pointed that out, George, to me previously. that, it's a failure of topical therapy, and the way they define it is that you're not responding, or there's not, or it's not appropriate, for some reason. And you and I know, and Lakshi, when we put someone in the hospital, and even if people have been in on cyclosporin or anything, we can get anybody to respond to topical steroids. And if you use a sauna suit, but that's not a feasible approach, is response to topical steroids. It's response to appropriate levels that are feasible for a patient for 20 years. And so I don't know if there's really true non-responders to topicals, to be honest, and maybe that's a provocative statement. But I don't think it's appropriate for most moderate to severe. I don't think they can use topicals for moderate to severe atopic dermatitis to adequately control their disease in the real world. Curious to hear your thoughts, Lakshi.
Well, I think it's really true, and I agree with everything you've said. But the way that I've looked at it, and I've really shifted a little bit away from the guidelines, just because of the patient experiences over the years and the stories they've told me, and just kind of, someone put it very clearly to me. When we're applying topicals to these patients, the fire is brewing, it's burning, right? We're not preventing, we're treating, as opposed to systemics, where we're trying to keep the fires from flaring. We're trying to keep it from showing up in a new place. So the fact that we're applying a topical doesn't mean we're really doing anything to prevent, except for perhaps moisturizing, right? But systemic therapy is actually, in my opinion, keeping the fire at bay, keeping it banked so it's not creating these hot spots where we have to apply the topical therapies. So I think that has been a shift for me. Certainly the guidelines have played that out, in that there is a lower threshold for moving patients away from topicals, and topical non-response, in my opinion, is anything the patient and the provider decide it is. And it doesn't take a lot for me to move a patient to systemic therapy, especially if you are asking the questions about quality of life and these patients are reporting that they're still unhappy. It's impacting their lives and their ability to live a joyful life. We are in a golden age of AD, where we now have amazing topical treatments that are non-steroidal. And so we have the luxury of being able to talk to our patients about these other opportunities to treat topically.
If you're ever thinking of giving systemic steroid with either intramuscular or prednisone, think about long-term control, because this is going to come back worse than it has started. And so that's the point when you should start thinking about, or probably even the visit before, when you should start thinking about better long-term systemic control with systemics.
Thanks for listening to this special episode of Beyond the Headlines, which was sponsored by Leo Pharma. Make sure to listen to Part 2, which takes a deeper dive into the selection of systemic therapies in AD.